Hi, everyone. Welcome back to the afternoon session. Really, the theme of this afternoon sessions is airways disease, inflammation, infection, and what wraps up all of those things nicer than Aspergillus. So our first talk this afternoon is going to be Dr. Rahimi talking to us about pulmonary aspergillosis. Dr. Rahimi?
Thanks so much, Dr. Frank. Good afternoon. I'm happy to be with you and cover the topic pulmonary aspergillosis. I'll go ahead and get started. These are my disclosures, not relevant for this particular talk. And I'll start with objectives. I'll provide an overview of the immune response to Aspergillus species, and then really spend most of the time reviewing the spectrum of pulmonary aspergillosis focused on diagnosis and management. In particular, we'll focus in on allergic bronchopulmonary aspergillosis, which is a hypersensitivity response to Aspergillus antigens, and then cover chronic pulmonary aspergillosis, followed by invasive pulmonary aspergillosis. And at the end, I'll do a summary and some kind of take-home points. So to start, Aspergillus species, particularly Aspergillus fumigatus, is everywhere in our environment, and we are on a daily basis inhaling a conidia from Aspergillus. But our standard, in healthy individuals, our standard innate immune responses, including mucociliary clearance and macrophages, can clear these and they don't cause any problem to the host, and we maintain a state of immune tolerance in the context of health. So while healthy individuals maintain immune tolerance, there's a real broad spectrum of diseases that can be mediated by Aspergillus species. And these really depend on both structural pulmonary disease as well as the immunosuppression status of the host. So in the context of particular airway diseases like allergic asthma or cystic fibrosis, those individuals, for complex reasons, can develop an allergic or hypersensitivity response to Aspergillus species in a phenomenon we call allergic bronchopulmonary aspergillosis. In individuals with structural lung disease, and I'll get into more details in subsequent slides, there's a diverse spectrum of chronic pulmonary aspergillosis syndromes, which I'll break down and cover. And then lastly, in hosts that are significantly immunosuppressed, Aspergillus can in fact cause tissue invasion and can be a very life-threatening disease state for which I'll cover in subsequent slides. To begin, I'll start with a case. 36-year-old man with allergic rhinitis and moderate allergic asthma presents with months of worsening symptoms, frequent ICS LABA use, including new onset productive cough with expectoration of brown mucus plugs. Laboratory studies reveal that the CBC shows a peripheral eosinophil count that's markedly elevated at 957 and a total IgE that is also markedly elevated above 1,000. And of note, previous eosinophil count was 300 and total IgE was 270. So elevated, but it's certainly gotten worse. And a CT chest is obtained given the worsening symptoms. And what it shows is significant bronchiectasis, particularly centrally, as well as these really profound areas of mucus impaction. So the question is, what is this disease state and how would you approach further diagnostic testing and management? And so this is meant to be kind of a very classic example of asthma-associated ABPA. So what exactly is ABPA? Well, as I mentioned, it's an allergic or Th2 or type 2 immune response to Aspergillus species, most commonly Aspergillus fumigatus. As far as the epidemiology, patients with underlying airway diseases, particularly allergic asthma or cystic fibrosis, about 3 to 13% can develop ABPA, so it's certainly not uncommon. And for a little bit more granularity as to why we call it a Th2 or type 2 immune response, I'll take a step back and mention that there's a particular type of T cell called a CD4 or helper T cell that really orchestrates immune response in hosts. And these CD4 T cells are initially naive, and they receive signals from specialized dendritic cells. And really, these dendritic cells are in our barrier tissues. They pick up environmental antigens, and they also assess the context for which those antigens are brought up. So when an innocuous antigen is sensed, that these DCs travel to a lymph node, communicate with a naive CD4 T cell, and communicate that whatever was picked up was innocuous. It shouldn't induce inflammatory response, and it'll instruct the CD4 T cells to become a suppressive type of T cell called a regulatory or Treg, as well as these anergic or lineage negative T cells that don't cause inflammation. Now, in people with allergic asthma and CF, for reasons that are complex, Aspergillus species can cause tissue injury and inflammation that the CDC2 can sense and will communicate to the CD4 T cell that this was actually not an innocuous, but actually a noxious antigen, a collection of antigens, and will induce what is referred to as a type 2 immune response, which involves a T helper type 2 program, as well as a T follicular program. These both produce IgE from B cells, as well as a variety of type 2 cytokines. And the host does this because these programs induce mucus and eosinophilia that's trying to get rid of whatever noxious antigens were encountered. But in the context of ABPA, it becomes overly exuberant and actually causes tissue injury, mucus impaction, and significant morbidity. And so what are the clinical manifestations of ABPA? Well, generally it's poorly controlled asthma or CF. And, classically there are these brown mucus plugs. Those aren't required, but if you patients note those, that can be a telling clinical sign. They may in fact have systemic symptoms, even low-grade fever, weight loss, and night sweats in severe cases. As far as the lab and imaging studies, canonically we do CBC with differential to assess blood eosinophil counts, IgE levels, and then that, along with total IgE, Aspergillus-specific immunoglobulins, particularly IgG and IgE. In addition, CT is a standard to assess for evidence of bronchiectasis, as well as mucus plugs. So there are a wide variety of diagnostic criteria. It can be somewhat confusing. One common question is, which of these various diagnostic criteria should be used by clinicians? And for this, I really like this paper that was published a few years ago in JACI in Practice, in which they addressed this particular question using latent class analysis. And for simplicity, I'll just say that there are a number of diagnostic criteria, including the Rosenberg-Patterson criteria, the kind of Isham diagnostic criteria. And what this study did, it was a prospective single center study of 543 subjects with asthma. And they had a multidisciplinary team classify based on the various criteria to see what was the best and most simplified series of features that could be used to make a diagnosis of ABPA. And what they came up with, I think, is more straightforward and easy to use, that for a diagnosis, all of the following must be present. Asthma, and that's one thing to note, is that while this study didn't include CF, I think it's reasonable to extrapolate into the context of CF, but having an airway disease that's a risk factor, such as asthma or CF, Aspergillus fumigatus specific IgE, and they give particular cutoff level, and a total IgE greater than 1,000. So it need to have all of the following criteria, and then two of the following: an IgG level of A fumigatus that's greater than 27, certain CT findings like mucus impaction, bronchiectasis, and then a blood eosinophil count of greater than 500. So I wanted to use our case and these criteria to ask, with these standard studies that we already have, how far away are we from really cinching a diagnosis? And so the patient has a known diagnosis of asthma, the total IgE level is greater than 1,000, and then both CT findings are present and the blood eosinophil count is greater than 500. So already all we really need to do, in addition to what we have, is to test Aspergillus fumigatus specific IgG and IgE, and that would be sufficient to help us make a diagnosis. So how about management? It remains that systemic glucocorticoids remain the mainstay of therapy for ABPA. In general, expert recommendations are to use prednisone or equivalent at about 0.5 mg per kg daily for 2 weeks, with tapers over generally 3 months, but these are, on a case-by-case basis. And I'll say that there's pretty good data in airway diseases that once you get to higher steroid doses than this, you're probably causing more side effects and not getting additional benefit with higher steroid doses. So starting at 0.5 mg per kg is very reasonable. As far as the role for azole or antifungal therapy, I think this is an important topic to cover. And it turns out that the best data we have is from a surprisingly small clinical trial that was done 25 years ago and published in the New England Journal of Medicine. This used itraconazole versus compared to placebo in only 55 patients with ABPA that were all treated with systemic steroids. And what they found is the addition of itraconazole for 16 weeks was associated with a significant increase in the likelihood of a clinical response, 46% versus 19%. So what was a clinical response? Well, it was really composite. It was a reduction of at least 50% in the glucocorticoid dose. a decrease of at least 25% in the serum IgE concentration, and one of the following: an improvement of at least 25% in exercise tolerance or pulmonary function tests, or partial or complete resolution of pulmonary infiltrates. And notably, the itraconazole was well tolerated and adverse events were similar in both groups. But really, this is essentially the best data that we have. And what I would say is that while itraconazole remains the most well-studied, Uvori and Posa are also used. In fact, they have better GI tolerance and better bioavailability. I will admit that the duration of azole therapy is not really well defined, but most studies recommend ranges of 3 to 6 months. And so one important question is, should the azole therapy be used right up front? Should it be used initially in acute ABPA? And the literature, there's some differences of opinion. It's an area of uncertainty. The IDSA guidelines recommend azole treatment as a part of initial therapy for acute ABPA. Other recommendations suggest reserving azole treatment for patients that you're unable to taper steroids. And I think it's reasonable to take a patient-centered approach. So if you have a patient that, let's say, has brittle diabetes and you really need to minimize steroid, both dose and duration, I think using the azole upfront certainly makes sense, and helping you try to taper off steroids. In the converse, if you have a patient that has a lot of drug-drug interactions that may preclude the use of azole or at least make it challenging, it's not unreasonable to try steroid therapy upfront, and then if you feel it's necessary, to add it on later. So I would think it's reasonable to take a patient-centered approach, since we still don't have rigorous data to define the use of azoles in ABPA. More recently, it's become a question of, should these newer type 2 cytokine biologics that are used in asthma, and they have very good rigorous data in the context of asthma, should these be used in ABPA? And there are no large clinical trials for this, but expert opinion, and I think very reasonable to favor using the biologic, because the underlying immunology is really similar to severe asthma, and there's good data in that context. But it still remains a question of which of the various asthma biologics should you consider. And as many of you know, there are several different classes, including anti-IgE, multiple anti-IL-5 pathways, one anti-IL-4 receptor alpha, dupilumab, and then the most recent addition, anti-TSLP drug. And so there are no head-to-heads for these various biologics. There's a very nice paper from the Boston University Pulmonary Group that looked at trends in the treatment of ABPA. And here on the top panel, they're looking at the percentage of patients that received oral steroid, antifungal, or biologic. And what you can see is that steroid, not surprisingly, remains standard in a majority of patients are receiving steroid therapy. And then in more recent years, the use of antifungal has seemingly declined, and there's more use of biologic. And I really think it is very reasonable to use biologic therapy. As far as which one, while we don't have head-to-head, it's not surprising that anti-IgE has fallen down in use. And I think the reason for that is that while there are many indications where anti-IgE therapy is particularly useful and should be a kind of frontline therapy, in allergic asthma, it doesn't seem to be as effective as the other biologics. And so I think that that's why you're seeing a decrease in the use of omalizumab, an increase in the other biologics. Among these three, I think any of them would be reasonable to use. In my own individual practice, I lean towards dupilumab upfront. The reason for it blocks IL-13 signaling, and IL-13 really promotes the mucus response, which is a major feature of ABPA. There is always a concern that with the addition of dupilumab, there's a brief period where peripheral eosinophil counts go up. But what I'll say is most of these ABPA patients, while they have marked eosinophil, they generally are on systemic steroids, which suppress that response. And so for those reasons, I tend to go with dupilumab upfront, but I think any of the bottom three classes would be reasonable to use in the context of ABPA. One other thing to note is that while Aspergillus fumigatus is the most common fungus that drives this particular pulmonary syndrome, there are a large number of allergenic fungi. All of them, a number of them are listed in this table, and it's recognized that there are certainly clinical syndromes that fall into the blanket of an allergic bronchopulmonary mycosis, where it's the same phenotypic syndrome, but not due to either Aspergillus fumigatus or another Aspergillus species. I would say, management would be similar. It's more difficult to do serology testing on these particular diverse fungi, but I would say that steroid therapy and biologic therapy would still stand as the kind of main treatment modalities. Okay. Now, after kind of an overview of ABPA, I wanted to take a transition away from this allergic clinical syndrome to this broad category of chronic pulmonary aspergillosis, which actually is the most complex among these Aspergillus-associated pulmonary diseases. So to start, I wanted to present a case, a 58-year-old man with a history of active TB that was adequately treated with 4-drug therapy, and that was relatively remotely, and then now presents with months of new cough and recent small volume hemoptysis. 3 sputum AFB smears and a TB PCR are negative, suggesting that this is not recurrent TB. And in fact, initial mycobacterial cultures are also negative. And a CT chest is performed and shown. And what you can see here is a large cavity that has a fungus ball present in it. So the question is, how would you approach further diagnostic testing and management? And so I want to focus on the definition of chronic pulmonary aspergillosis here. It's really a spectrum of chronic pulmonary diseases due to localized Aspergillus infection. So as opposed to ABPA being an allergic response to the fungus, this is really an infection that can be at various different degrees of invasion. And so the epidemiology is that individuals with underlying structural lung disease, plus or minus immunosuppression, are at risk. Certainly pre-existing cavitary lesions are the most common, but COPD, particularly with bullous disease, sarcoidosis with structural lung disease, lung cancer, lung transplant, and even a history of thoracic radiation can predispose individuals. And again, that this is really a spectrum that can be parsed out in a number of ways. And one is the degree to which the hyphae are either, in the tissue or not in the tissue. And so, for example, when there's no hyphae in the tissue, these are chronic forms of pulmonary aspergillosis, including aspergilloma. And generally, as far as the pathology, there's no angioinvasion. The hyphae are kind of confined to a pre-existing cavity. The host probably has, pre-existing structural lung disease, but is relatively immunocompetent and tends to be a very, very chronic process that can be stable for a very long time. In contrast, there can be invasion, local invasion, even without angioinvasion, but associated inflammatory and necrosis in the tissue. These are individuals that tend to have more significant immunosuppression and can be a more progressive disease process. And then, angioinvasive disease really is in individuals that have very significant immunosuppression, including profound neutropenia, and really can be very acute and life-threatening. And so I've parsed out this category of chronic pulmonary aspergillosis into a variety of clinical entities, just allowing it to be more easy to define. And I'll go through these one at a time. And so first, an Aspergillus nodule. They lack any pre-existing cavity. There isn't any evidence of invasion. And in general, there's no way to tell this from a cancer nodule. So in general, the diagnosis is made by biopsy. And one thing to note is a diagnosis of one Aspergillus nodule does not define the etiology of the other nodules. So there could be one Aspergillus nodule and then other nodules are of a different etiology. So what's a reasonable approach to an Aspergillus nodule? Well, one thing is that it is always dependent on the host. And so dependent on whether they're immunocompetent and whether or not they have immunosuppression, either mild or severe. And so in both immunocompetent and mild immunosuppression, the first question is whether or not the nodule was completely resected at the point of biopsy. In immunocompetent individuals, or in mild immunosuppression, if it's completely resected, you're done. No antifungal therapy, no additional imaging, curative disease. In immunocompetent individuals, if it's not completely resected, we generally don't do antifungal therapy, but just follow them with serial CT imaging. If there's evidence of growth, then that would probably warrant antifungal therapy and close follow-up. In mild immunosuppression, if it was not completely resected, then the recommendation is antifungal therapy and then follow-up CT imaging to ensure that it's at least shrinking and if not resolving. And then because of that severe immunosuppression puts the host at significant risk for invasive disease, an Aspergillus nodule in someone with severe immunosuppression, you really should treat it as invasive disease And in the later slides, I'll get into the treatment management for invasive disease. Okay. So after an Aspergillus nodule, there's all this phenomenon, like in our case, of a simple aspergilloma. So this is a fungus ball, generally in a pre-existing cavity without significant surrounding inflammation. If there is any inflammation, it's really just within the wall of the cavity. Patients can be often asymptomatic, but they can have a cough plus or minus hemoptysis. In contrast to a simple aspergilloma, there are two overlapping categories: a chronic cavitary pulmonary aspergillosis, and this is Aspergillus infection with symptomatic and radiographic progression. And these symptoms they have symptoms that include cough, dyspnea, chest pain, and hemoptysis. And then a subset of these individuals can develop a really profound fibrotic response. And there's an independent term, chronic fibrosing pulmonary aspergillosis. Essentially, this is a subset of CCPA just with extensive fibrosis. The reason why some hosts develop extensive fibrosis and others don't is unclear, but that's really the difference between these two clinical entities. And so what are the diagnostic criteria for these chronic pulmonary aspergillosis? Well, it can be challenging, honestly. There's thoracic radiologic findings that are necessary, including one or more cavities with or without a fungus ball or nodule. Direct evidence of Aspergillus infection. This can be challenging, needing microscopy or culture from a biopsy. Alternatively, you can use, immunological responses such as, antibody responses to Aspergillus or PCR. You have to exclude alternative diagnoses. And then in general, to find this as a chronic process, the duration of symptoms or radiologic changes should be for at least 3 months. So the one thing that I do want to warn people about is that the direct evidence of Aspergillus infection is being a challenge. And so in this schematic, it covers all the various forms of the host response to Aspergillus species, as we mentioned, hypersensitivity in the context of ABPA, and then these various forms of Aspergillus infection in the context generally of structural lung disease and immunosuppression. But it's important to know that people that have particularly certain types of airway disease, that Aspergillus can just colonize the airway. So just because it grows from a sputum culture, or they have an antibody that's positive, or you get a PCR from a sputum sample, you have to really put it in the clinical context, because it could very well just be airway colonization and not a clinical problem. So there can be certainly false positives, as I mentioned. And then on the other side of that, some of these diagnostic studies that we use, including, serum galactomanins, can have can have false and negatives. And so we should be mindful on both sides. Okay, so going back to our case, how would you approach further diagnostic testing and management in this individual? So this was a Aspergilloma, and again, it depends on the host. And so if severe immunosuppression, they have to treat as invasive disease. In immunocompetent or mild immunosuppression, one of the main features that determines how management and diagnostics and management will proceed is whether they have persistent hemoptysis. So if the individual has minimal symptoms and doesn't have persistent hemoptysis, generally it's serial CT imaging. The order of time is generally wouldn't wait longer than 6 months, certainly sooner if the person has worsening symptoms. If there's no progression, you would just define it as a simple aspergilloma and follow that person clinically. If there is, in fact, evidence of radiographic progression, and the patient also may have ongoing cough, very reasonable to assume that this is CCPA or CFPA and treat with antifungal therapy. Now, if the individual has persistent hemoptysis, then you need to intervene on that. And in general, the two particular interventions that are available are bronchial artery embolization. That's generally used as a temporizing measure, ideally a surgical intervention if the patient can tolerate that, in addition to azole therapy. And what I would say is that as far as duration, there's really no rigorous studies, but azole therapy generally when we treat is for 4 to 6 months. And in this category, if azole therapy fails, then you end up, even if there isn't persistent hemoptysis, going back to surgery. Okay, so we've covered these diverse clinical presentations of chronic pulmonary aspergillosis. I wanted to note that there is this one entity that really straddles chronic pulmonary aspergillosis with invasive aspergillosis. It's probably dependent on only mild to moderate suppression as opposed to severe immunosuppression. And so for these reasons, the field has given it the term subacute invasive aspergillosis. And as I mentioned, features straddle CPA and invasive disease. Usually there's progression of over 1 to 3 months, whereas invasive aspergillosis is generally more quick. It commonly exhibits constitutional symptoms, and there are a variety of radiologic findings, including infiltrates, nodules, and consolidation with or without cavitation. Okay. And so with the time that I have remaining, I want to cover the last category of invasive aspergillosis. Okay. So what's the definition? This is, as I mentioned, invasion of Aspergillus hyphae into the lung parenchyma, and often there is can be angio invasion. As far as epidemiology, generally these are severely immunosuppressed individuals. That's kind of the classic presentation of prolonged immunosuppression. Individuals that have severe neutropenia, hematologic malignancy, stem cell transplantation, or prolonged and intense immunosuppression. One thing that's important to note are that there are emerging risk factors, and we've become to recognize that some critically ill patients, including those with severe viral pneumonias, can have superimposed infection with Aspergillus that can in fact cause invasion. And then more recognized is that patients with severe liver disease can in fact develop invasive disease. As far as the criteria for invasive pulmonary aspergillosis, the field has broken it down into proven, probable, and possible. So as with all of these syndromes, it can be a challenging diagnosis, and you have to put all of the clinical pieces together. So proven invasive pulmonary aspergillosis, the gold standard is a sterile specimen with either direct microscopic identification of hyphae or a positive culture from a biopsy. Often clinicians are faced without that ideal scenario. And so then it comes down to, probable involves at least having one host risk factor, such as, prolonged neutropenia, stem cell transplant, prolonged corticosteroids, generally thought to be at least 0.3 mg per kg for, 3 weeks or greater to be at risk. They also need to have at least one clinical feature, like CT findings that are consistent with invasive pulmonary aspergillosis, and there are certain radiographic features such as halo sign or air crescent sign or cavitary disease. And then some mycological evidence of aspergillosis, either a positive on microscopy or culture from either sputum or BAL, or a positive antigen assay, galactomannan or beta-D-glucan, knowing that the sensitivity of those can be and specificity are imperfect. And then possible is generally what you're left with is a host of factors, some clinical features, but you don't have mycological evidence of aspergillosis, and then you just need to make a clinical decision of the risk and whether it's warranted to do empiric therapy. As I've alluded to, these serum fungal markers that we use, beta-D-glucan and galactomannan, a couple of notes about this that is important to know, that which fungal species are they positive in? I have them listed here. And then also to note that mucor, which is a significant pathogenic mold, will not be positive. There is a negative for these fungal markers. And then note that the sensitivity and specificity, particularly of serum beta-D-glucan, is not ideal. Among these, the best test is a BAL galactomannan if feasible. And then everyone should be aware of the false positives with these serum fungal markers. And this is a really nice, case series that, as I mentioned, there's emerging risk factors for invasive pulmonary aspergillosis. And this is a case series of influenza and COVID-19 associated pulmonary aspergillosis that includes postmortem as well as lung biopsy showing, in fact, Aspergillus invasion into the tissue. For the sake of time, I won't go over the entire study, but a helpful thing to know that in very critically ill patients, particularly severe viral pneumonias, if there's features of it that don't completely make sense or radiographic features that are atypical, that certainly this is a clinical diagnosis that people should keep in mind, because antifungal therapy will be absolutely necessary and can be life-saving in these individuals. Okay, so how do we approach diagnostic and management? Again, to stress that this is can be a very life-threatening condition. So when there's a concern for invasive aspergillosis, upfront treatment is warranted, even if you don't have a definitive diagnosis, and each clinician has to kind of make a decision about when to treat. As far as diagnostic testing, you can parse it out into non-invasive testing, as mentioned, sputum or BAL fungal stain, a sputum fungal stain in culture, or serum fungal markers. If they do support a diagnosis of invasive aspergillosis, if the whole clinical syndrome is consistent, then you go with an antifungal course, and I'll get into the treatment modalities in the coming slides. If it doesn't, and there's still a high probability, if possible, invasive testing is ideal because of improved sensitivity and specificity, in particular bronchoscopy with BAL, including fungal culture and BAL galactomannan. And I'll say that while these mold fungi can grow on typical bacterial culture media, really ideal to request actual fungal culture and stain for these. If it supports a diagnosis, then yes, and if it doesn't, then you go with an alternative diagnosis. But a key feature is that when there's a high concern, you may warrant antifungal therapy as you try to gain diagnostic information. Okay, what are the antifungal agents and how should you approach actual therapy? There are a number of classes of antifungals to consider, polyenes, azoles, and echinocandins. The general approach to antifungal therapy for invasive pulmonary aspergillosis is voriconazole plus or minus an echinocandin, particularly if severe disease. There are alternative antifungals, including posaconazole if they're for sustained visual disturbances, isovuconazole for prolonged QTC, and then amphotericin B for patients with drug-drug interactions with azoles or severe hepatotoxicity or azole-resistant aspergillus infections. And then to note that antifungal therapy for suspected mold of unclear etiology really should be amphotericin B to cover other molds such as mucor until you have additional diagnostic information. Okay, and so now I just want to summarize that we, over the course of the 40 minutes, really covered the wide spectrum of the host response to Aspergillus species. Healthy individuals maintain immune tolerance in patients that have asthma or see if they're at risk for this allergic response, allergic bronchopulmonary aspergillosis. And then in structural lung disease, there's a diverse spectrum of chronic pulmonary aspergillosis syndromes. And then in severe immunosuppression, the concern is for invasive aspergillus infection. And with that, I'll stop my talk and I'll be at the panel discussion and happy to take any questions.